Emergency services.
Great.
Okay, tell me exactly what's happened.
Stop breathing.
A karate training session has taken a horrific turn for a 46-year-old male.
He was doing exercises. We've done chest compressions, quite a bit of stuff.
Okay, if you can turn him on his side, clean out the mouth and nose. Is he awake?
No.
Is he breathing?
No.
Okay, I've already got help sent out for you there, okay? I need you to stay on the line, okay?
The patient is given the highest priority.
Micah 30 received, priority 0.
Paramedics Leonard and Cullen are immediately dispatched. Leonard recently qualified to be a mobile intensive care ambulance paramedic, known as Micah, after years of specialised training.
Suspected cardiac arrest.
Roger.
So, you know, this is what Micah's all about, isn't it?
Yeah, well, it's game on this job. Being a Micah paramedic has been a lifelong dream for me. It's a pressure that I haven't felt before, but it's very rewarding at the same time. You're helping people in their darkest days. No guarantees with jobs like this.
Absolutely.
This is the most serious job that a Micah paramedic or any paramedic will attend. When a patient is in cardiac arrest, their heart has stopped pumping and they're not getting oxygen to their brain or their vital organs. And within minutes, the patient can die.
I've also organised the fire brigade that can help with these situations, so they might arrive first, okay?
Come on, stay with us.
Now, is there a defibrillator available?
No.
Okay, listen carefully. I'll tell you how to do the resuscitation, okay?
Yep.
Place the heel of your hand on the breastbone of the centre of the chest.
Yes.
Right between the nipples. Put your other hand on top of that. Pump the chest hard and fast, at least twice per second, 5 centimetres deep. We're going to do this until help can take over.
Yep.
We're going at this rate. Count out loud so I can count with you. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4.
CPR's in progress.
I suppose you'll probably gain our IV access. I'll take...
Yeah, you look after him.
I'll look after
Go on
him.
that side, I reckon.
Yeah. I'll just have to be in my
The chances of surviving a cardiac arrest are actually pretty low. For every minute that this patient's heart is not beating, there's a 10% less chance of survival. And only 35% of patients leave hospital alive after a cardiac arrest.
I've got a waiver. It's fireys.
Some karate guys.
We're very lucky that fireys can attend these cases and perform initial life-saving treatment, including CPR and defibrillation, to try to get the heart beating again.
G'day guys, Colin from the ambulance.
Performed one shot.
Yep. How long to your next changeover?
Probably about another minute.
Yeah. Airway's a bit gurgly, Leonard, so we might need to move this up.
As we arrive, a shock has been delivered by the fireys, but the patient's heart is not beating, so he's clinically dead at that point in time. And I know straight away we're going to have to give this everything we've got, and even then, it might not be enough to save this patient.
So how many shots? One. Yeah, one shock. CPR immediately, I believe, from the other people in the group.
There's really two phases to a cardiac arrest. The first challenge is getting the patient's heart started again. The fire brigade have their defibrillator to deliver a shock to the patient's heart to hopefully enable it to restart again and beat normally. It's pretty much like a reset button on a computer.
All right, one shot.
Yep. Stop CPR.
He's got a pulse.
Now we've got a pulse, and this is where phase 2 begins.
Pull the AP airway out. Turn your suction on.
We need to protect their airway to ensure that they get as much oxygen to their brain and organs as possible.
Airway's incredibly solid. We'll need suction there. Have you got suction, guys? So how many shots? One.
We suction the airway to make sure it's clear and then proceed to ventilate the patient with oxygen. We've got the heart beating again, but the patient is not breathing effectively.
He's taking some breaths. I'm going to get one of you fellas to take the airway. Just hold the oxygen on him for the moment.
And we don't know if he's going to have another cardiac arrest in our care. And who knows how much damage has already been done to the organs. If there's been a prolonged amount of time where the brain has been starved of oxygen, that patient may be brain dead.
Hey, mate. Can I get one of you to do a 12-lead ECG on him straight away?
The younger students are sent home, while karate sensei Giovanni remains on site, still reeling from how the night's unfolded.
We're on the ground just doing our back stretches, and as we were lying there, I heard just this weird breathing. As we sit up, one of my students was on his knees and keeled over. basically his face on the ground and struggling to breathe.
Sharps away.
So I pulled him up and everything was tense. His neck was tense, his jaw was closed, his eyes were semi-lidded as well, and he then started going blue because his breathing had stopped. 000 was called, the operator guided us through the compressions. I am trained, but yeah, nothing ever quite prepares you to use it in such a serious situation.
Keep just watching his breathing.
He's a really lovely guy and he's really caring. And then seeing him on the ground in the way that he was, nothing ever prepares you to see someone, you know, possibly dying.
Leonard, I reckon at this stage we're going to need a set of fire aside.
Yes.
Back with the 46-year-old karate student, his heart is beating again. But Leonard and Cullen are concerned about his breathing.
His airway looks relatively clear. I've given him a good suction, so I'm happy with that at the moment.
Even though the patient is breathing, his breathing isn't effective enough to deliver the right amount of oxygen to his brain and organs.
We're going to basically intubate this person.
So we need to take over his breathing and RSI the patient, or rapid sequence intubation, which means that the patient won't have to breathe on their own, but oxygen can be fed directly into his lungs via a tube that ensures the airway stays open.
I'll start setting up my tube gear.
Even though the patient is not conscious, he must be heavily sedated, then given a paralysis drug to avoid the gag reflex, rejecting the tube going down his throat.
I'll start setting up some RSI drugs. I'll quickly drop ketamine.
So we're going 100 kilos, Leonard.
Yeah, mate. So 150 of ketamine and 100 of rock.
Yeah.
This is a very dangerous procedure because it's a procedure that involves us putting the patient into an induced coma and then paralysing every muscle in their body, including their breathing muscles. So once we push that paralysing agent, we have only a very small window of opportunity to get a plastic tube into their windpipe.
Okay. Are we attached to oxygen? Everything's there.
If we take more than a few seconds, that patient's oxygen levels are going to plummet dramatically, and if they get too low, that patient will go back into cardiac arrest, and we may not get them back.
All right, I'm ready to go, mate, here.
With me being so new into MICA, it's a procedure that I get nervous about.
Ketamine going in.
Yeah.
Rock uranium in.
Yeah. I'm just going to wait for relaxed jaw tone for optimal intubation conditions. All right, relaxed jaw tone. So taking this off. So entering the oropharynx.
You just hope that all that training and all that study is going to work out or the patient dies.
Going further down, past the bougie.
Intensive care paramedics Cullen and Leonard have paralysed all their karate patients' muscles, including the ones for breathing, so they can feed extra oxygen to his lungs via a tube.
Bend that a little bit, curve it a little bit for me, mate.
Until we pass the tube, the patient isn't breathing. So the longer we take, the longer the patient is being starved of oxygen.
Yep, that's through. And then we'll ventilate.
Once I insert the breathing tube, just because I think I've seen it go into the right hole doesn't necessarily mean it is. So I have to give a few breaths to the patient and watch on my monitor for clear indicators that I have done it successfully.
That's still 99%.
99%.
Confirmed.
Yeah, good job, Leonard.
No worries, mate.
And once I see that his oxygen levels are improving, there's a massive internal sigh of relief.
We're just going to secure things and then we're going to start moving.
We've done it. The patient's airway and breathing is stabilised from here on in.
So, guys, the intubation was successful. Short downtime, and it looked like would have been pretty good CPR from a karate group. So hopefully we'll have a really good outcome.
Ready, set, go. Yep, perfect.
Although we've stabilised the patient and taken full control of their airway, breathing and circulation, the patient's not out of the woods.
Let's move in slowly.
We actually don't know what's the cause of the arrest. And because we don't know, they can re-arrest at any point in time, and that's why it's critical that we get to hospital really fast.
I'm just going to run through the checklist. Yeah. So airway's fine. There's no secretions of vomitus that I need to worry about. The tube, it's 23 at the lips.
And we don't want to miss anything. Highly stressful jobs, no matter how experienced you are, you're open to forgetting something because your mind is thinking about 1,800 things at once. So checklists are a lifesaver.
And we've got end titles confirmed, yes. Sats are good still.
As we arrive at hospital, I know that we've given the patient the best chance possible, but that doesn't mean that he's going to have a long-term prospect of survival.
The fight starts now. He's going to end up in intensive care. He's going to be there for a significant amount of time.
Yep.
There's no guarantee that he will wake up, and if he does wake up, we don't know what condition he will be in.
Tell you what, you earn your keep at these jobs, don't you?
Oh, mate.